This is Healthcare Now Radio's Trending Now. Get ready for an exhilarating 30-minute ride through the latest topics driving change in digital health across the news and social media. Join us as our subject matter host takes the lead in uncovering what's hot and what's not. So buckle up and tune in to stay in the know.
Welcome to Trending Now on Healthcare Now Radio, where we explore the forefront of healthcare innovations and transformations. I'm your host, Shahid Shah. Today, we're really excited to have Marten Haring, the CEO of Lirio. What's trending now and what Marten and I are going to discuss is the transformative potential of AI-driven behavior change in healthcare. That's a mouthful, but really what we're trying to explore today is most of healthcare is about healthcare delivery is where we almost always think about it. But what we don't realize is that so much of the delivery of healthcare is dependent on the behavioral science of how do you get people to do what is in their best interest in a timely fashion, right? That's normal behavioral science that marketing and sales and other teams know really, really well. And this is where, Marten and I are going to have a great conversation is how can we use artificial intelligence and modern LLMs and next generation technologies to drive meaningful patient engagement and improved health outcomes through this science of behavior understanding, behavioral change. So a little bit, sometimes this sounds icky, right? There's like, what do you mean you're using a computer to make me do something that I don't want to do? But really what we're trying to figure out is how do we get you as a patient to do what we know is good for you, but make it seem like it's your idea, right? And that's the whole science of behavior change that we're going to be talking about. So Marten, welcome to the show. So Lirio's work on AI-driven precision nudging is really, really cool. Now you've talked about hyper-personalization in healthcare, which is why we're having this conversation. And this term gets thrown around a lot. So what does Lirio think about, quote, hyper-personalization, and how's that different from what everybody else is doing?
Well, thanks for having me on, and you're diving straight in. So, think of hyper-personalization as a term that really describes using AI and data to personalize experiences. And in many industries, using data and AI is really focused on simple transactional objectives. How do I sell more product? It's quite transactional. In healthcare, it's a lot more complicated. If you think about, especially engaging with the healthcare systems, those are fairly infrequent interactions. And as a consumer, I don't really think of them as transactions where I get some kind of instant payoff. I may have an objective of living my best healthy life, but I can walk out of a physician office and go into the grocery store and buy that, a bag of M&Ms and not really think about what we talked about. So the challenge of using hyper-personalization in healthcare is very different than other industries. And really, we have to make sure that the toolbox that we use to accomplish hyper-personalization is appropriate for healthcare. So a very simple example from the real world would be, I'm a Starbucks, loyal Starbucks customer. Starbucks is frequently looking at my past transactions, looking at when I come into the store and saying, hey, Marten, you can get some extra rewards if you buy an extra coffee coming in after 2 p.m. because that's not your normal habit. Think about this in healthcare for a moment. Using that kind of predictive analytics to put recommendations in front of me, I would say, well, Marten, it looks like you had a knee operation last week. Why don't you come in for another knee operation, on Friday? We actually have an opening for you, right? That wouldn't work. If I go to Netflix and I watch movies, there's a huge science that goes into my choice architecture of, hey, let's recommend a movie to Marten based on what Marten has watched before or people like Marten have watched before. Well, you don't want to be the patient that goes into your patient portal and says, hey, Marten, have you considered using these medications because, people like you also have them? It would completely, undermine the trust in the system and in your physician. So the challenges we have of hyper-personalizing in healthcare are real. And we believe that really a big portion of this is because we're not trying to optimize for a transaction, but really for optimal care, optimal health. And the starting point around that has to be, what are really the types of interventions that are relevant to me as a patient? Once I understand what's relevant for me to make sure that I live my optimal health, now I have a question of, well, how do I actually motivate myself to take those actions? And sometimes things get in the way. Even if I'm motivated, things get in the way of me being able to take the actions to actually complete those health behaviors. And so I need a little help and a little support. So we think that AI-driven behavior change is really how you need to solve for hyper-personalization in healthcare. And it turns out we also believe no one else has cracked that code. And so we think we're onto something really special, really defining the problem as behavior change and the toolbox of using behavioral science, many different techniques to try and help support, motivate people to overcome barriers to actually complete those important health behaviors. So that was a mouthful, but it is sort of the big difference between other industries and healthcare to begin with. And then when you look at who is solving for personalization in healthcare today, they're not really solving for behavior change. They're not even solving for hyper-personalization. These are companies with omni-channel platforms that say, hey, does Marten prefer to get communications via email or text messaging? Maybe he has a patient portal account. And personalization is all about the choice of modality. Maybe you're lucky if there's a communication preference that says, do you want to communicate in English, and do you want your communication to come at 8 o'clock in the morning or at 5 p.m.? But those are very generalized preferences and don't really take into consideration that we are people that get influenced daily by things that are outside of our control, and the things that are important when reminding me to take my medication are going to be very different than when you're trying to get me to schedule my annual well visit. So, a lot of the state-of-the-art personalization capabilities in healthcare today are really just about plumbing. They're all about, how do I reach a patient based on consent and preferences, not really how do I get them to actively change their behavior and make certain choices.
No, I love that. So as we look at your direction, I think that the perfect examples you gave is, no, I'm not going to want a second knee appointment 2 weeks later, or the med just because my friend has the same med. Those are awesome examples of where it's not the same. But what if people want to know, well, what is the same? Why is it that in healthcare we don't do the simple things like Starbucks and others do? Not the complex ones that you're talking about, but are there simple things that we're missing, just low-hanging fruit?
Well, yes, I think it's really simple, because we're still talking about me. I'm the Starbucks consumer. I'm the healthcare consumer. I'm the Netflix consumer. And so my expectations of the organizations and people interacting with me is still the same. I expect you to know something about me. And if I actually volunteer to share information with you about myself, I expect you to use that to help me make things more convenient. And so if you show me that, you are different, that's okay. But I have an expectation that you're still adhering to some of the very basic principles, that you care about me, you know me, and you're really trying to optimize, for the best outcomes for me. And so I think consumer expectations, especially in a digital world, right, are very consistent across all interactions, media, companies, et cetera.
Yeah. And so before we put our propeller hats on and talk about the tech details, let's talk about some of the real world things that you guys have been able to achieve. your collaboration with Cone Health was pretty interesting. From what you mentioned to us was that about 30% of disengaged diabetic patients got converted to primary care visits thus far. Those numbers sound way too good to be true. So tell us a little bit more about that. How did that work, and how did you achieve those metrics?
It's really interesting because the work we're doing with Cone Health is sort of very much at the forefront of tackling, I think, the reasons why we believe AI-driven behavior change is going to be transformational to healthcare. Right? If you think about CDC numbers, they will tell you on their website that about 90% of the cost of healthcare today, which is inching up towards 20% of GDP, $5 trillion. You think about why are we incurring such high costs? And much of it is driven by patients that have chronic conditions, one and often more than one chronic condition, or mental health conditions. And when you think about patients that have this kind of that live in this kind of reality where it's hard for them to change daily behaviors. Oftentimes, we're not just we don't have a simple fix for patients who have chronic conditions. It's not, hey, I'm gonna go see my doc and I have a problem, I have a cough or a throat ache, and I'm going to get prescription, and a week later I'm going to be fine. We're talking about frequent routine behaviors that have to be changed and influenced, and that's hard. That's really, really hard, which is why as a society we really want to help and support people that are either in that state or are rapidly progressing towards acquiring chronic conditions or mental health conditions, to really stem the tide and reduce the cost and improve their quality of life. Cone Health is a partner for us that, if you look at their patient population, it really is a microcosm of that problem. Greensboro, North Carolina, population made up of patients that suffer from hypertension, diabetes, more than one chronic condition. And the care team there is extremely innovative and leaning into saying, how can we tackle population health in a new and interesting way? And by the way, you look at the demographics, and you also have to make sure that you are dealing with patients with very different type of ethnic, racial backgrounds, different levels of motivation and engagement with the health system. So it truly is a very interesting population from a scientific point of view, a challenging population from a clinical or medical point of view. And so what we found is, let's start tackling that population around hypertension, diabetes, with not just our platform that can really start hyper-personalizing the way we reach out, text messaging, patient portal, email, based on assumptions we're making about population, but then also very much focused on, how do we talk to each patient differently? What are some of the assumptions we're making about what things might be getting in the way of someone with hypertension, scheduling an appointment with their physician to really talk about a treatment plan? And we found that one of the really successful interventions or behavioral science techniques that we're using specifically for hypertension patients is combining sort of the approach we're taking, thinking about action planning. How do we actually get to the finish line, with an offer from Cone Health to offer help with transportation? So I may be motivated to go and see my physician if I have hypertension, but how do I practically make that possible? Well, we have a solution for that, and we communicate that solution as part of the intervention. That may not be the right way to communicate with every patient, but for some patients with that kind of barrier, it might be the difference between showing up for that appointment and not even bothering to schedule it. And for diabetes, we see a very successful use of a technique called information about health consequences. So really trying to outline for people with diabetes why that visit with their clinician is so important to prevent, further damage to their bodies, help them with some of the symptoms that may be impacting their life, some of the choices they have to make. So go see your physician before these consequences really impact your health further. And so these are just examples of how that very personalized approach in that particular population is proving that patients who previously weren't engaging to schedule these appointments are not only scheduling them, but showing up for them.
That's a big deal. Like, the scheduling is often the easy part, it seems like, but getting them to show up is pretty hard. So if you're just tuning in, you're listening to Healthcare Now Radio, of course. This is Trending Now, and I'm Shahid Shah, your host. I'm talking to Marten den Haring from Lirio. He's the CEO there. And we're discussing the transformative potential of AI-driven behavior change in healthcare. Marten's taught us a little bit about how behavior change can be done using AI. In thoughtful, disciplined, and non-creepy ways. And so as we get to the next half, talking about some of the details, tell us a little bit, Marten, about your large behavior model. What is that in as non-technical terms as you can? And then expand to talk a little bit about, is this just another word for analytics like we've been doing for many, many years? Or are we going to get more value out of this because it's more than just analytics or diagnostics?
Yeah. Let me break it down, and I may have to get back to you on the second part, depending on how lost I get in my own explanation of the first one. So we use the term large behavior models to really use some of the industry education that really has happened over the last 2 years around generative AI and generative AI architectures. A big ingredient in generative AI architectures are large language models. And really the premise at a very high level is that we're using documents, information that is published on the open internet to really train machine learning models to predict the next word in a sequence, to generate content, but based on content it has seen before, whether again it's textual or images. These large language models basically work on the idea that you're ingesting a lot of information and using that information to accurately predict, for example, the next few words in a sequence of words. That works really well when you're trying to generate language data. It doesn't quite solve the problem of how do I understand what is unique about each individual, what motivates them, how I adapt, maybe using prompts, how I program the output of my large language models to look differently for each person. Because there is no real information on the public internet available that describes who I am. And if there is such information, we have a big problem, right? And so we created this notion of a large behavior model that really protects personal health information, personally identifiable information, organizes in the way that our algorithms can really process that data and really make decisions and predictions about which behavioral science technique, using inputs around content, frequency, channel choice, et cetera, of how to reach people. How do we use the information we have about people, how to predict the right recipe to activate and influence each individual? So we call those large behavior models. So you have large language models that people are familiar with. The big difference, of course, in healthcare is that so much of how we want to engage people and influence people starts with a very clear objective. So we can't program a system to say, oh, just try and create optimal health for Marten, right? It's really difficult, if not impossible, to teach a machine learning program that. What we can say is, we want Marten to make sure that he complies with the standard of care, we know that Marten in the next year is eligible for these types of clinical interventions. It might be an annual well visit. It might be a certain type of cancer screening based on my age and family history. It might be making sure that I get vaccinated for certain types of seasonal conditions, etc. So there is a standard of care that makes me eligible for certain types of interventions. Those become the objectives in my overall modeling. Now, how do I use data about Marten to actually try and optimize for each of those objectives? As I am watching and experimenting, because I know what the objective is, I know who I'm trying, to get to that objective, I'm trying different techniques to see what's effective and what's not, and I'm using different kinds of ways to incentivize or reward my machine learning agent architecture to really get to the objective that I have in mind. Doing that requires a very different architecture than a generative AI architecture. So we talked about LLMs and LVMs conceptually. The architecture of how you get there is going to be very different. And so the industry talks about something called objective-driven AI that really learns by observing an environment in which we are active. And so this idea of letting a machine learn by observation, understanding which objective it is trying to optimize for, in many ways is sort of the next step. It's a level of innovation, a type of architecture that is more complex, more difficult to implement, and to train accurately, reliably than generative AI architectures. And when you look at the industry, you'll see even companies like OpenAI that are at the forefront of generative AI innovation talk about their next horizon for this being autonomous agents. And so you think about the concept of autonomous agents, you think about newer, more complicated AI architectures like objective-driven AI, you think about why that would be a good fit from trying to influence health behaviors, and you have the perfect match. Because so much of what we're trying to do in healthcare is to adapt to human beings. We are not the same human being today that we were last week. We are influenced by different events, different things that happen in our lives. So we are constantly changing. We may have very different habits that have formed, very different values that influence different types of choices. How we choose to be vaccinated for flu may be very different than we choose to get vaccinated for COVID. So just within decisions around vaccinations, we may have very different norms and values that inform our decisions and actions. And so what we really have to do is to put a system in place that learns human sort of preferences, that is empathetic to decisions that humans make without trying to always recommend things that are known or decided a priori. So we're excited about this brave new world. We think we're a couple of years ahead. I hope it wasn't too propeller heady or geeky. I was trying to explain it, but we're basically leaning in to using data and machine learning to really focus on optimizing for very specific health objectives, all of which come back to the simple idea that the person we're trying to communicate with and observe really needs to be at the center of this, needs to be motivated. We believe in sort of this concept of self-determination, and really the best form of motivation to help change people's behavior over time has to be that you're supporting them, motivating them, and that motivation needs to be intrinsic. And so trying to throw incentives like financial rewards at people is not going to be helpful. You learn very different things when you're observing those types of incentives. So again, it all comes down to how do you represent the problem of supporting people's health decisions in the real world? How do you represent that to a computer, to a machine? And how do you really teach it the right patterns, the right things, trying to optimize ultimately for sustained optimal health? So
yeah, no, that was a great.
Hopefully that wasn't too complicated.
No, it's definitely not complicated at all. In fact, just in the last couple of minutes that we have, maybe talk to us for about a minute to a minute and a half. Let us know who would be ready to accept a Lirio-like solution. Like, do you have to have all your data already prepared in certain ways? What do you guys do to say, okay, if you're going to benefit from Lirio, here's what we can do. Here's what you need to already have in place. Have an EHR, have a little bit of data. Tell us where that goes in the last couple of minutes.
Yeah, I would say you're spot on. You need a level of maturity about how you think about your data. What data you have may inform what types of use cases we can support, what kinds of outcomes we can support and enable with our platform. But bottom line is, you need to have data about the population we're communicating with on your behalf. So that's number one. Number two, you need to have, I think, a very clear framework in place that governs the interactions with your consumers. So do you have consent to actually communicate with your consumers about their health, making sure that that is in place? Because if not, you not only are not following the proper regulations around what you're allowed to communicate to people about when, but you're also making it much harder for people to really receive the messaging and to make the right choices, because it becomes harder to motivate someone when you're reaching out without their consent, right? So I think overall, what we're trying to shoot for is a maturity on data, people that really believe that it's important to start looking at outcomes using the data we have about people and machine learning capabilities as sort of the next frontier. So leaning on data, leaning in on technology, and having that overall framework in place for consent for being able to do the outreach.
Yeah, and I think one of the key things you've taught us today is that this is not state of the art 10 years from now, right? This is state of the art today. If you feel like you can handle this for patients, you can do this today. And the way that I see this in our marketplace now, as we talk to multiple partners and others that come onto our show here, is there is a lot more in AI that we used to about 5 years ago think about the future. Now, this is all here today, and it's just about the delivery organizations and healthcare delivery providers and their administrators and executives actually just saying, okay, if now that we can do this, we have our EHRs, we have our basic analytical systems, we're doing a little bit of personalization in terms of modality of communications, et cetera. But let's bring in some experts like Marten, like Lirio, and let's go forward on this hyper-personalization, because it can pay for itself pretty quickly. So with that, we've exhausted our time today. So Marten, thank you so much for your insightful perspectives on the transformative potential of AI-driven behavior change today. Hyper-personalization is real, and we can do it in healthcare. With that, before we wrap up, if you want to reach out to Marten, go to lirio.com. To our listeners, thank you so much for joining us on Trending Now on Healthcare Now Radio for this engaging discussion. Stay tuned for more episodes coming up soon. Thank you very much.